We're going to talk about the issues around boosting, and this is particularly relevant to this population, and so it's a really good opportunity to discuss with you some of the challenges we have around the policies, around education, around the procedures, and in utmost really is how we protect the clean athlete in this respect. Autonomic dysreflexia is this phenomenon which is unique to athletes with spinal cord injury at the level of T6 or above, and so it is something that only occurs in Paralympic sport. It does not occur in able-bodied sport. And it's a phenomenon that can occur spontaneously or deliberately, and it results in a large rise in blood pressure and a reduction in heart rate. The problem is that it's dangerous. Uncontrolled, this has led to cerebral hemorrhage, strokes, myocardial infarction, seizure, and death. And so for many athletes with a high spinal cord injury, they will carry with them an emergency car to warn medical staff that they may come across who have not any familiarity with their particular condition, that they have a spinal cord injury and they're susceptible to autonomic dysreflexia, because it's a really dangerous condition. However, athletes found out that actually, while they were in a dysreflexic state, they could actually exercise more intensely. And so they started using this technique deliberately to actually improve their performance capability. And there have been a couple of studies which have actually observed that and measured the change in performance capability using boosting to deliberately induce a dysreflexic state. A couple of studies. The initial one from Burnham and colleagues in Canada showed approximate 10% improvement in a simulated 7.5 kilometer race. So if you could improve your race time by nearly 10%, that's a real incentive for people to think about using these sort of techniques. It's a massive increase. We talk about the concept of marginal gains and making little small percentages of improvement, and 9.7% is massive. So the IPC took a position on this, that recognizing that autonomic dysreflexia is a serious hazard to health with these potential disastrous consequences, and although it may happen spontaneously, but it may be deliberately, known as boosting, the IPC forbids athletes to compete in a dysreflexic state. And furthermore, any attempt to deliberately induce autonomic dysreflexia is forbidden and will be reported to the technical delegate, and the athlete will be disqualified from that particular competition, regardless of the systolic blood pressure measurement. So how is a dysreflexic state determined in IPC sports? And this occurs for athletes just prior to competition, and there's a process of notification of the athlete that they've been selected for testing, and the testing will occur no more than 2 hours before and no less than 10 minutes before their event, and a blood pressure measurement is taken with an automated, clinically validated and calibrated sphygmomanometer. And if the systolic blood pressure at the moment is greater than 180 milliliters mercury, if it's less than that, they're cleared to compete. If it's equal to that or greater than that, then they're retested again after 10 minutes. If it's still above that, they're withdrawn. If it's below that, they can then proceed and compete. So since Beijing in 2008, at European Championships, World Championships, the IPC have been doing a testing program trying to determine what are the values that occur during athletes just prior to competition. But it does throw up a number of questions to be considered. Which athletes do we test? And the answer obviously is all those athletes who become dysreflexic, who could become dysreflexic, i.e. those with a spinal cord lesion of T6 or above. But the next question is, does the sport have details of all athletes' medical history with details of lesion level? Well, unfortunately, not always. When I was doing the European Championships a couple of years ago in Swansea, we found that in the athletes with permanent classifications, long-standing in athletics, the cause of their impairment wasn't always recorded. Now, this is improving as time goes on, but we have a transition phase where there are a number of athletes where the actual impairment isn't always recorded on their classification details. What about the exact lesion level is unconfirmed? Are they motor complete or incomplete? What about the sensory level, because it relates to the autonomic dysfunction? So how do we know whether someone has the capability to have autonomic impairment or not? Which sports to test? Okay, well, theoretically, those sports with athletes who could become dysreflexic, and that's a whole host of sports where athletes with a spinal cord injury could be participating. However, if boosting is shown to enhance performance of aerobic capacity, should we only be testing athletes in these sports? So are we testing for a health hazard, or are we testing for attempted cheating? And at the present time, it's targeted testing in sports where performance enhancement is possible. So what threshold of blood pressure should we set to determine when to withdraw an athlete when it may be unsafe? So the answer is logically one that's hazardous to health or indicative of a dysreflexic state, and one that can be also justified scientifically in event of a legal challenge. Because if you withdraw an athlete from the gold medal event at the Paralympic Games, you've got to be fairly certain that you've got some strong grounds to do that on. So what threshold of blood pressure is set and why? Well, at the moment, it's equal to or greater than 180 millimeters of systolic blood pressure. Now, when this level was introduced, this threshold was introduced, we need to be able to reflect on some other authorities' guidelines about when you would not exercise. And the ACSM, American College of Sports Medicine, guidelines on exercise testing suggest that you should not exercise someone if they had a blood pressure equal to or that level. But we didn't know whether that was relevant to this particular population because we did not have the data. So did that threshold represent appropriate levels for athletes with spinal cord injury in the warm-up and pre-race situation? Because we don't know what the usual level of blood pressure is when you've just warmed up and exercised and now you're all keyed up, you're ready to take part in this gold medal event. Is that the same as if you go into your doctor and sit down in a calm situation and he measures your blood pressure? And that data wasn't available. So that led to the IPC monitoring program. And since 2008, there have been 135 athletes who've been tested. Majority of those have been in athletics. None of these athletes have declared pre-existing high blood pressure. So it is a duty of the NPC physician to declare in advance any athlete who has hypertension so that we can take that into consideration. And if you're not doing that, that's something you need to do. So there have been no declarations that we knew from what the team physicians had declared that none of these athletes had pre-existing hypertension. And from that, we see that the mean systolic blood pressure in athletes in the core room is approximately 131 millimeters of mercury, and we can see the maximum minimum recorded values. So if we look at that, we found 6 readings involving 4 athletes where they were outside 2 standard deviations above the mean for those values. One reading was greater than 180, but when that athlete was retested after 10 minutes, that blood pressure dropped to 164, and so that athlete was permitted to compete. So what it says at the present time, no athletes have been withdrawn from competing based on the blood pressure value. So we start to plot that out and look at the data for the athletes. What we see is this trend here, but there appears to be this little deflection point here, which raises the suspicion that there are a small number of athletes who are utilizing the technique of boosting or becoming dysreflexic, which is raising their blood pressure above a normal level. So by utilizing this data, it is leading us to suggest that we reduce the threshold for detection of autonomic dysreflexia to 160 millimeters of mercury, and this will need the IPC governing board approval. We also take very seriously the comments that coaches and other people say to us. And there are things like, that athlete, he always drinks 2 litres of water in the core room, and then he's out on the track before competing, and he's tapping his bladder, trying to induce a boosted state. You can see he's boosting. He's that guy, he's always boosting. You can see when he's finished his skin coloration and so on. So we have comments from other athletes and coaches who think that there are people out there who are cheating. So what constitutes a deliberate attempt to induce autonomic dysreflexia? How is it evidenced? If it's occurring on the track or the field of play, then there needs to be a clear process for that identification. What level of evidence do we need to have to withdraw someone? Does that need to be video evidence, or can that just be the observation of one of the medical committee? How do we then interact with a technical delegate to withdraw that athlete because they're out on the track and they actually participate in the race, and then how do we deal with the results management? So these are things that which are very difficult, but we need to think about, are we protecting the athlete who isn't cheating if we don't take this seriously? Peter alluded to this earlier in terms of education. We did a study in Beijing in 2008 looking at attitudes and knowledge about boosting. And 40% of susceptible athletes who were questioned were unaware about boosting, but 17% of athletes questioned admitted to using boosting during training and or competition. But we haven't caught anyone yet. So 17% of athletes questioned admitted to using boosting during training or competition. So we need to work on education. We need to look at how do we engage with the new young athletes to ensure that they don't start to adopt dangerous and illegal practices. We need to work with you. We need to work with the coaches, the international federations, the NPCs, about what the condition is, why it's important, the procedures that are undertaken, and the pre-notification of hypertension. And we need to do symposia like this to take this information out to make sure that this gets back to the athletes and the coaches. We can use things like social media, perhaps. We can put information on websites. But we also I think we need education stands. Like in the dining hall in Paralympic Games, WADA always have a stall, and you go along and you'll answer a quiz and get a free hat or something like that. We need to make sure that we engage with athletes and talk about it and put that information more available. Because ultimately, we need to be protecting the clean athlete. If there's an athlete who's not winning their gold medal because someone else is cheating, then we're not doing our job properly. We need to talk about educating the athlete, and we need to protect the clean athlete, and we need to protect their health. So this is something which we really need to engage with you as the sports with to help get your feedback. I think we need to collect more baseline data on athletes, a bit like a biological passport in terms of blood pressure, and then look at what it is between rest and the call room situation, and make sure that everyone is aware that this process is being undertaken for good reason to protect the clean athlete. Thanks very much.